So we've reached the half-hour mark, so let's get started. First off, I'd like to welcome everyone to this week's installment of AMSSM's National Fellow Online Lecture Series. My name is Matt Wise. I'm an assistant professor in family medicine and orthopedics at UT Southwestern. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on x-rays of the hip and knee, which will be given by Dr. Robert Boutin, professor of radiology at Stanford Medicine 1 week from today at the same time. For tonight, I am very excited to welcome Dr. Donald Kasitinon to speak to us on ligamentous injuries of the knee. Dr. Kasitinon graduated from medical school and completed his PM&R residency here at UT Southwestern in Dallas, Texas. He then went on to complete sports medicine fellowship at Stanford University. He's now an assistant professor at UT Southwestern and associate program director of the PM&R residency. Dr. Kasitinon currently serves as team physician for the USL Super League's Dallas Trinity FC, Dallas Baptist University, as well as UT Arlington's Moving Mavs and Lady Moving Mavs. Before we get started, we also like to mention the goals of the National Fellow Online Lecture Series, which are to serve as an adjunct to your individual program's educational content, to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest experts, and most importantly, to assist in CAQ exam preparation. And some reminders to please mute your device's microphone and turn off your video. Please submit questions through the chat function in Zoom. I, as the moderator, will ask the questions during the Q&A at the end, and please complete the evaluation at the end of the lecture. Lastly, one of our new efforts is to facilitate more input from our audience. There are a couple of ways to do this. First, a web link can be found by going to amsssm.org. Click the Education tab and then select Fellow Online Lecture Series. The link is near the top of the page, as is seen in our screenshot here. You can see my cursor. It's going to be this blue highlighted, and then it takes you to this form indicated by the yellow arrow. Second, and this is the more simple option, is to scan the QR code. It should take you directly to the form to fill out. And when filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for fellows. Now, without further ado, please welcome Dr. Kasitinon.
Awesome. Thank you so much, Matt, and thanks for the invite. Let me see. Let me go and share my screen. All right. Can y'all see it?
Yeah, it looks great.
Awesome. Cool. Well, yeah, so thanks for those of you who are joining tonight. You know, Dallas is about to go through a snowstorm for our cases, so I think our city's going to be shut down over the next 2 days. But some free time. Tonight we're going to go over knee ligament injuries. Some of this is relatively basic, but then I also wanted to add in some like newer like literature and evidence on ways to treat these different injuries and how we can really counsel our patients as the non-operative side dealing with these injuries. You know, definitely like Matt said, if you have any questions, put them in the chat. I'm more than happy to answer them at the end of the talk. So, in terms of objectives, tonight we're going to review normal anatomy and biomechanics of the ACL, PCL, MCL, and LCL, and then highlight the history and physical exam for these ligamentous injuries. Then discuss imaging for these injuries, and then finally review treatment and return to sport for these injuries. All right. So in terms of knee anatomy, you know, these are the 4 major ligaments that we'll discuss tonight. The ACL, the anterior cruciate ligament, the posterior cruciate ligament, the medial collateral ligament, the lateral collateral ligament, and we'll have a little bonus of the posterior lateral corner, which is sometimes like, you know, not talked about very much, but I think it's important to bring up when we talk about these ligamentous injuries. And just as a reminder, you know, whenever we'll talk a little bit within the anatomy of each, but then it's always helpful to like use your hand, like use your right hand when you're looking for a right knee to see if you cross your fingers like your third over your second finger, then you'll see that the one that's like anterior, that's on the lateral femoral condyle going to the anterior portion. So that's your ACL, and then vice versa for your second finger. And if you do it for the left side, it's the same thing. Great. So, you know, you always want to start with some neurovascular supply. So remember that you have your geniculars in terms of the neuro supply. So you have the articular branch of the tibial nerve, which gives you intra-articular innervation, also gives you sensation around that knee. And then you have your nutrient artery to the tibia, which is below the PCL insertion. And then finally, you have your genicular arteries that have a rich anastomosis at the knee. And these geniculars up here at the top are a big reason why whenever you learn about like genicular nerve blocks and genicular nerve ablations, because they have that sensory innervation, that's how they work. And then finally, you have your saphenous nerve, which primarily provides a sensation over to that medial side of the knee. And occasionally, if someone has medial sided knee pain, that doesn't really seem like it's just from knee arthritis. Saphenous nerve blocks can be effective. And then some borders are the posterior border is sartorius, superficial to the gracilis, and anterior to the semitendinosus. In terms of knee biomechanics, as a reminder, the knee is a diarthrodial joint. I always have a hard time pronouncing that word, but remember that's a freely movable joint that allows for a significant amount of movement, made up of a joint capsule, synovial membrane, and some synovial fluid. So the knee counts as a complex diarthrodial joint, as it has two or more articulating surfaces, as well as some fibrocartilage. That's in comparison to like the hip, which just counts as a simple joint because it only has two articulating surfaces. And the knee also allows for simultaneous rotation and translation, as you can see in these dynamics. We always think the knee is just flexing, but it's actually rotating and translating at these different joint locations. And also with your articular cartilage, you have type 2 collagen, mostly water, and then as increased water and decreased proteoglycans whenever you start to develop degenerative disease or arthritis. Now, in terms of anatomy and biomechanics specifically for the ACL, as I kind of mentioned in the two slides previous to this, it comes off your lateral femoral condyle and attaches to your anterior tibia. Generally, it's about 33 millimeters by 11 millimeters, and then you really have two bundles, which I think we don't often talk about. But you have your anterior medial bundle, which is tight in flexion, and this is the primary limiter in terms of translation of the tibia. And then you have your posterior lateral bundle, which is tight in extension, and that controls rotation or the rotary component. Um, Here are some good diagrams, like an arthroscopic picture of the anterior medial bundle and then the posterior lateral bundle. And then here's a cadaveric diagrams that show the same. And then something that's sometimes asked is like what supplies the ACL? And always remember it's the middle genicular artery. And then just keep in mind, we think of it primarily as that anterior stabilizer, as well as some like rotary stabilization, but also the secondary restraint to varus and valgus stress of the knee. And then in terms of, I kind of mentioned primary restraint to anterior tibial translation. So if you have the absence of an ACL, it results in functional problems, including rotary instability during cutting and pivoting activities, and also gives your knee some endangerment if you are ACL deficient, because you can develop some meniscal and or chondral injuries, and that can lead to early arthritis. In terms of the anatomy for the PCL, this comes off your medial femoral condyle and then goes to your tibial sulcus, close to your posterior tibia. It's slightly bigger than the ACL. It's usually about 38 millimeters by 13 millimeters. And you also have two bundles of the PCL. You have your anterior lateral bundle, which is tight in flexion, your posterior medial bundle, which is tight in extension. And then you also have some meniscofemoral ligaments. The anterior one is called Humphrey, and then the posterior one is called the Risberg ligament. And this is also supplied by the middle genicular artery, just like the ACL. Right. And then the MCL anatomy is a little bit more simple, but it just comes off that medial femoral condyle and goes down to that medial tibia. Remember that you have a superficial and a deep layer of the MCL, and we'll see on some of the imaging pictures later that the deep always inserts or attaches to that medial meniscus. So oftentimes if you have injury to that deep MCL, you'll usually have an injury to the meniscus as well. And the main job of the MCL is to resist valgus force. Then you have your LCL or fibular collateral ligament or lateral collateral ligament. That comes from your lateral femoral condyle and then attaches to your fibula. It's cord-like, tight in extension, and the capsule's most distant extent is just posterior to the fibular head. And then there was like an interesting study from 2009 that looked at the biomechanics strength using like robot models of each of these ligaments, and it found that the ACL can support about 2,200 newtons, the PCL can do about 2,500, the MCL is about 4,000, and then the LCL is, I guess, the weakest. It's about 750. And then just the bonus, the posterior lateral corner. So if you aren't familiar with this, I don't think you necessarily have to memorize all these different structures. Maybe some of the major static stabilizers are important to remember, some of the dynamic stabilizers. But the major static stabilizers are the LCL, the popliteus, which remember that's the often forgotten muscle sitting behind your knee. It's like the key to the knee. It unlocks it. So when you're in full extension, your popliteus creates that first like internal rotation and then the flexion that allows you to bend your knee. That's why it's like the key of the knee. And then you also have your popliteal fibular ligament. And then you have some other static stabilizers, including your lateral capsule, your arcuate ligament, and then your fibular ligament. And finally, you have some dynamic stabilizers, including the biceps femoris, the popliteus muscle, the IT band, and the lateral head of the gastroc. So history, we learn about all these different things, but some of this is going to end up being some test taking. These are kind of the key features that you'll see in the question stems whenever they're talking about certain ligament injuries. So if anyone feels like a pop and then followed by a big swelling in the knee, typically it's an ACL injury. If there's a dashboard involved or someone falls on a flexed knee, often a PCL injury. And then from about valgus stress, you'll get an MCL injury, varus stress, LCL injury. And then finally, if they mention any sort of locking or if your patient's seeing that their knee is locking up on them, that's typically a pretty significant meniscus injury. Okay. In terms of exam, I did want to play this video, so hopefully it works. This kind of covers 3 exams in one video. This was a knee that I saw in fellowship. It was kind of a unique situation because I think this patient essentially got in like a big accident and required an X-fix for some of his fractures. And got an X-fix at a hospital, but then was lost to follow-up because of insurance reasons. And then when he showed up to another ER because his insurance wasn't really going to cover anything, they removed the X-fix but didn't fix any of the ligamentous injuries he had. So this was probably the most major ligamentous injury I've seen in a while. And even before I start the video, the first thing you can see is that his tibia is already like pushed backwards. So that's going to be the SAG sign, which is indicative of a full PCL injury. So let me play this video. Initially, you can see there's that posterior drawer that's really going back, and then here's the anterior drawer where you see his tibia really translating forward. So here I highlighted, so like I said, initially you have a SAG sign, which is when you have someone sitting there in 90 degrees. If their tibia is just sagging posteriorly, then you have to make note of that. Also, it's important to know in any exam because if someone already has a sag sign and you try to do an anterior drawer, then you may get a false positive just because it started out further back. And then we also saw the posterior drawer that was being done initially in this video, and then finally the anterior drawer where that was the last test that he did. So I'm not going to play this whole video, but the next test is going to just be the Lockman, which I think many people are familiar with. You'll have someone's knee just in about 20 degrees, and then you'll support from the back of their tibia, proximal tibia, and then support like their distal femur. And you want to just give it a little translation anteriorly. The key thing to know about the Lockman is it's not really a test that you would say negative or positive on. There's a grading system behind it, right? So if you want to, so there's a numeric system and then you say A or B. So in terms of numbers, if they have like 0 to 5 millimeters of translation, that's a 1. If they have 5 to 10 millimeter translation, that's a 2. And then if it's greater than 10, then it's a 3. And then probably more importantly, with A and B, A means that you feel a firm endpoint and B means that you don't really feel a firm endpoint. You feel some give way. Because 2A could be normal for someone who's just a little bit lax, but everyone should have some sort of endpoint. And you oftentimes want to compare side to side with this. Next one, this one's a pivot shift test. So on the pivot shift test, the test is performed by the examiner who applies like valgus force to the knee, and then in some internal rotation to the tibia, and then you slowly flex the knee from extension. And then the test is positive if the tibia like subluxes anterolaterally on the femur. indicating ACL injury. And this really works primarily because of the IT band. So in extension and internal rotation, the lateral tibia plateaus subluxes anteriorly, but in flexion it reduces and may clunk. And that's because the IT band serves as an extensor when the knee's in extension, but it serves as a flexor when the knee's flexed. So that's how it really utilizes that mechanism. And then the last test that I'm really trying to make more popular is Lely's test. It's also called the lever sign. I think it's not as popular. There's an initial paper that came out that showed it was actually the most sensitive and specific test, but then there's a secondary paper that showed that it was not. So I think that's why it lost a little bit of popularity, but I think it's cool to show. I'll just kind of describe it. So you can see on this person, so you put your fist around like the proximal third of the tibia. And then you put your other hand on top of your distal thigh, and then you just push down with this hand. The whole concept is that if you have an intact ACL, then the heel would raise off the bed. But if your ACL is not intact, when you push down the femur, the tibia actually just translates anteriorly so that the heel doesn't come off. So that would be a positive test if the heel stays on the bed. And then with varus and valgus testing, for valgus testing, you want to push. So valgus, you want to push on that lateral side to give them that valgus stress. Varus, you want to push from the medial side to give the varus stress. And then valgus is testing MCL, varus is testing LCL. You typically want to do this with the knee flexed at about 30 degrees because that isolates the MCL and LCL. If you do it at 0 degrees, usually they should really only have laxity if the ACL and PCL are also injured. And then finally, you have your prone dial test. This one's to test like the posterior lateral corner. So the way you do this is you have them prone, and then you you take their knees, bend to about 30 degrees, and then from there, you want to try to externally rotate their tibias. And then you really look from side to side. If there's a greater than 10-degree difference in terms of external rotation from side to side, then that side that externally rotates further probably has a significant posterior lateral corner injury. And then you can do this at 90 degrees If the test is positive at 90 degrees, that indicates that they likely have a posterior lateral corner injury. Right. So those are the major physical exam findings for each of these injuries. So we'll go over imaging now. So for imaging, initially you want to always start with x-rays. This is just to rule out any significant fractures, but assuming that they don't have any big fractures, two of the signs that you may see on your test that can indicate a ligament injury on x-ray. The first one is a deep lateral femoral notch sign. So this is also called the deep sulcus sign. So this is like an indentation over here at that lateral femoral condyle, and that the mechanism is really from hyperextension or impaction injury from the collision of the femoral condyle whenever the person's getting the ACL injury. Another thing that is more commonly tested is called the Sagan fracture, and you'll usually see a little like ellipsoid fracture coming off that lateral tibial plateau. And this is seen oftentimes, like if you see this fracture pretty much 75% of the time, it's an ACL injury. So it's nearly pathognomonic. And then it's still in contention about what's the actual mechanism for the Sagan fracture to come out. I think the lead theory is that it's a result of the avulsion of the middle third of the lateral capsule whenever you have that twisting injury that causes ACL injury. And then, us being really into ultrasound nowadays, and ultrasound can definitely help you in clinic. I think a lot of times, like if a patient has a huge effusion, you don't necessarily need to check, but if the injury occurred a while ago or they just don't really have a significant effusion, a lot of times it can be helpful just to look at it under ultrasound and see if you do see a significant effusion compared to the contralateral side. And just as a reminder, so when you're looking at this ultrasound image, this is the image of the knee and long axis. This is proximal, this is distal. So you see your patella, your quadriceps tendon, your suprapatellar fat pad, your prefemoral fat pad, and then you have your bursa in between. So in this case, this person does have like a moderate effusion. Okay. Then you can also take a look at the MCL with your ultrasound. So here, highlighted down here, you have your superficial layer of your MCL and your deep layer of the MCL, and there's your medial meniscus, and that would be the position of your probe. So you're in long axis to these structures. You can often, while examining, also put them in valgus stress to see if you have a lot of stretching of that ligament or any gapping of that ligament to see if there is any significant injury. Also, another point to make is to make sure that you look at the entirety of the MCL. It is a lot longer than you often think, so it comes off this proximal femoral condyle and then can go all the way down, usually pretty far down your tibia. Here in this case, on this image, you actually see, like, if this was a live image, you would see something beating here. These are actually, you can see your inferior medial genicular, like artery, nerve, and vein oftentimes when you're looking for this. And if you went a little bit more distal, you would see your pes coming in more cross-sectional area. Then you can also take a look at your LCL and then also do some varus stressing to see if you have any laxity there. And then there are papers out there looking at the ACL under ultrasound. I'll admit I've tried to do it a couple times. I'm not sure if I'm confident enough to really call like an ACL deficient. Well, I guess an ACL rupture from my ultrasounding. But if you were to try to do it, you can use a curvilinear probe, and you're typically trying to look underneath, like to the side of the patellar tendon, and looking for this deep structure that's located right here in this image. Oftentimes I've been able to find it, but then like I also like if I'm not able to find it, I don't know if it's because it's really not there or because I'm just not doing a great job looking for it. And then finally, oftentimes you'll just end up getting an MRI for a lot of these patients. So whenever if you're looking for the ACL on an MRI image, the sagittal view tends to be the best view to look for that. And you'll see usually you should have a structure coming down here, but then in this case, this ACL is just completely blown up. And then another thing you can look for is similar to that deep sulcus sign that we had talked about before. On the MRI image, oftentimes you can see like a pivot shift bone bruise. So you'll see a bruising pattern here on that middle third of that lateral femoral condyle, and then on the posterior third of that tibial plateau. And then for the PCL will be coming from here to here. So in this case, in this image, you'll see a torn PCL. And then some images for the MC. Oh, wait, I did want to go over the double PCL sign. This is not a ligament injury, but just a nice finding and something that maybe will impress your attendings if they ask you. Is that here it looks like this person has two PCLs, but what it really is, it's a bucket handle medial meniscus tear where this top one's a PCL, and then this guy is just that meniscus flipped up over itself. Okay, so that's pathognomonic. So if you ever hear double PCL sign, it's a bucket handle meniscus tear. All right. And then looking at for the MCL, you can see here. So this is what a normal MCL should look like. And then this is an MCL sprain. You can see the fibers are still continuous, but it just looks like there's like a lot of inflammation around there as well as like a sprain pattern. And then here is some images for an LCL. So here you'll see an LCL coming down, but on this one you can see a tear in that proximal portion of the LCL. Right. So now we'll go over some of the more details about the actual injuries and then how to treat these and return to play for these. So for ACL injuries, it's a pretty big deal. There's approximately 400,000 reconstructions done a year in the US. Typically, you have it from non-contact pivoting injury. The patient will usually describe a pop followed by an effusion in over 70% of these cases. An acute ACL tear has a higher incidence of lateral meniscus injury, while chronic tear is more associated with medial meniscus injuries. And then female athletes have a 4.5 times risk compared to males. The theories behind this include females having a smaller tibial notch, having increased valgus during landing, having increased ligament laxity, and also being quad dominant compared to the hamstrings. And notably, like ACL repair usually is like I guess not the right nomenclature. Usually you want to say ACL reconstruction, and that's just because the ligament itself is not really suitable for primary repair. The ruptured ends are covered by myoblast-like cells with alpha smooth muscle actin. Really, only time that you may be able to get a repair for the ACL is if you have a proximal avulsion. Okay. And before we talk about more of the treatment, we want to think about ACL tear prevention, which should be a large role in our clinics and when we're counseling our athletes and trying to prevent this injury that will really pull them out of sport for a long time. So here's an article from AJSM that was in 2020. It included 8 prospective randomized control studies, and it found that ACL injury prevention programs significantly reduced injury rates by 53%. There was significant variability in exercises between the programs, though. Most of them focused on plyometrics, landing technique, and agility. And then for ACL rupture treatment, so non-operative treatment include is usually done for those patients with low demand, less laxity, and asymptomatic partial tears. And then for most of our younger active patients, then we would recommend ACL reconstruction, and this really reduces the incidence of chondral and meniscal injury in the long term as well. So here, looking at prehab, so this is an article from AJSM in 2016. It compared functional outcomes 2 years after ACL reconstruction between a group with extended prehab and neuromuscular training versus a moon cohort who didn't have this. In the extended preoperative rehab group demonstrated significantly improved outcomes and higher return to pre-injury sport. The prehab was 2 sessions per week for 4 weeks, included strength training, plyometrics, balance, and proprioception. So prehab is still very important for surgical outcomes. And then in terms of graft options, oftentimes your surgical partners are going to be the ones that go over this, but you'll find in your clinic that patients, if you find an ACL rupture in your clinic, they'll ask you a lot of these questions. I think it's very good to know about their options and kind of not make a choice for them or not like set them on a certain path, but at least give them that background information before they even talk to your surgical partner. The big choice is first autograft versus allograft. We'll go over that a little bit more in the next slide, but in general, autograft is usually done for the younger, higher demand patients, and the allograft maybe for someone who doesn't need as strong of a graft. The autograft choices include your patellar tendon, oftentimes shortened it's BTB, which is just bone to bone. And that's just because when they take the graft, they're taking a piece of that distal patella and then taking a piece of that proximal tibia. So you do have that bone to bone integration on both sides of that graft. The negative side of that is you might have a higher incidence of anterior knee pain from the graft itself. And then another choice is a hamstring. This typically is the semitendinosus and gracilis tendons. This one has the highest strength and stiffness. There is a higher infection rate when compared to patellar tendon. And it's important to remember, just keep in mind this whole fact that they're taking the graft from the semitendinosus and gracilis. Sometimes you'll see patients in clinic, or I saw one in training room recently who had a ACL reconstruction with a hamstring autograft. It was doing very well, but his hamstring was feeling kind of strange. And then I think another provider had ordered an MRI that showed that he didn't really have a semitendinosus, which he freaked out about. But then just be the smart one, know in the back of your mind that that's because that's where the graft came from. And then something becoming a little bit more popular is a quadriceps autograft. This one is 1.8 times as thick as a patellar tendon, so maybe a little bit less like morbidity in terms of anterior knee pain. And there's also more intra-articular volume. And then for autografts, return to sport, usually about 6 months. Depends a little bit on the surgeon and the athlete, but that's generally the time frame. And then for allograft, you have your same options of BTB, hamstring. You can also get a quad tendon plus minus a bone block, Achilles plus minus a bone block, and then they often use tibialis posterior anterior tendons as well. Return to sport for allograft tends to be a little bit longer, usually about 9 to 12 months, because it takes a little bit longer for the allograft to really incorporate within the patient. All right. So this is a study from 2015 AJSM. This was looking at a military population. It was a randomized study with long-term follow-up, minimum of 10 years. They looked at 48 autografts and 49 allografts. They found that there's no difference in subjective stability, IKDC, Tegner, and SANE scores, but there was a 3 times increased failure rate for the allograft. So they found 8.3% versus 26.5%, which is why I alluded to a lot of times you'll want to lean toward that autograft for someone who may be still doing a lot of explosive or cutting sports to reduce that risk of a failure. And then to summarize some of these positives and negatives, so for BTB, some of the positives include low rate of failure, low rate of residual instability, bony healing, and also just having a great track record over time. For hamstring, you have very low morbidity of the graft harvest. You have ease of harvest, great track record, and also maybe less knee pain afterwards. And then for the quadriceps tendon, you have a large cross-sectional area, more favorable tensile properties, reproducible graft size, and then ease of graft harvest, and then also potentially less knee pain. So some of the negatives for BTB, a little more likely to have some kneeling pain. You also have a risk of patellar fracture, patella tendon rupture because you're taking part of it, patella baja afterwards because of shortening of the tendon with closure, numbness to that region, and also changes to the patellofemoral joint and OA. Um, for the hamstring, some of the negatives include numbness, variation of graft size, potentially having to augment with an allograft, and also weakness or stability considerations during multi-leg reconstructions, and also higher incidence of graft laxity. And then the quad tendon, some negatives include possible patellar fracture, cosmetic deformity, hematoma formation, knee pain, and also potentially knee extension weakness. So whenever you're looking at these graph considerations, this was a study, a little bit outdated, but this is from 2014. It looked at 137 team orthopedic surgeons, and this was the NFL and NCAA football teams. And then the mean experience for these surgeons was 17 years. They did approximately 82 ACL reconstructions a year. And they found that 86% chose BTP autograft for starting running backs, and then 45% uh, chose BTB for the same age recreational athlete, and then 15% used BTB for 35-year-old recreational athletes. So this really just kind of shows that I think a lot of the surgeons still think that the BTB is the superior one in terms of not causing failure in the future, but maybe because of some of the anterior knee pain that may come with it afterwards, if it's a lower demand athlete, they will lean towards some of the other grafts. And this is just a picture of Joe Burrow, who is doing very well post his ACL reconstruction. Right. And then here is looking at an AJSM article from 2021, looking at 20 studies, quadriceps tendon versus hamstring tendon autografts for ACL reconstruction. So the primary outcome they used was a lesion score, and then they found no difference. And some secondary outcomes, they also found no difference in functional scores and no difference in laxity or failures. So honestly, the conclusion of this study was that clinical and functional outcomes do not differ. So choice of graft should be based on surgeon's expertise and familiarity. So this kind of, a lot of times you will end up, you'll kind of get the patterns of the surgeons you work with and which grafts they like to use. That's why it's good to just, maybe talk through some of this with your patient, but not really lead them to a conclusion, like I mentioned before. And then some possible ACL reconstruction complications. The most common cause of failure is just technical error. You can also have missed concurrent injuries, fractures, infection can happen afterwards. Staph epidermidis is more common, and the Staph aureus is second. This is something that's good to know too, like the cyclops lesion. So here's an MRI image, a sagittal image with the cyclops lesion listed here or located there. So really a cyclops lesion is a nodule fibrovascular tissue with arthroscopic appearance of a cyclops. A lot of times patients post ACL reconstruction can complain of painful anterior knee mass, and then they have a hard time extending their knee and they can feel like a click at terminal extension. Okay. And, interesting to our field, PRP, we do a lot of it, right? And then there's a little bit more research at looking at PRP and ACL reconstructions. So the rationale behind it is that it could reduce failure rate, it can enhance recovery time, growth factors to enhance graft maturation, reduce donor site morbidity at harvest site, and also there have been some promising animal studies. So you can see it's made the New York Times, made a health magazine. So patients will ask about this. So here is a study of the utilization of orthobiologics by sports medicine physicians. I think most of these were surgical sports medicine physicians, but current use as of 2021, 66% of orthopedic AOSSM members used orthobiologics, 71% reported increasing use in practice, and 30% of users attested to using PRP due to competitor influence. So something we really need to get like some research nailed down in. So here, an article, a systematic review looking at ACL reconstruction with PRP and published in Arthroscopy in 2020. They found no clinical improvement in any functional outcome scores, no significance in VAS score for BTP grafts. And so then they concluded that the current evidence does not support the use of PRP with ACL reconstruction. Then going even further, here's a study that was published in AJSM. It was a retrospective matched case control study, PRP augmentation of meniscal repair in the setting of ACL reconstruction. And then there were 160 that got PRP and 162 that did not. With 2-year follow-up, they found no difference in any outcome scores except range of motion, which was actually less than the PRP group. So their warning was to be cautious with the application of PRP during ACL reconstruction because it could potentially lead to some sort of negative outcome. But more recently, we've had some other studies looking at PRP with some of these ACL reconstructions, and this first paper called it faster healing. It's also been said to have faster remodeling of patellar tendon grafts and also reduces tunnel widening. So you can see the evidence behind PRP and ACL reconstruction keeps swinging back and forth, but I think it is something that's good to know and be able to counsel some of our patients about. Once someone gets an ACL reconstruction, thoughts about postoperative bracing. So here is a randomized control trial comparing the effectiveness of functional knee bracing and neoprene knee sleeves following ACL reconstruction. It's published in AJSM. So 150 patients were randomized to a functional brace or a neoprene sleeves at 6 weeks post-op, and outcomes were assessed at 6 weeks, 12 months, and 24 months using these outcome measures. Conclusion was that there really was no significant difference at 1 year or 2-year follow-up. So evidence doesn't really support the use of a functional brace afterwards. So a neoprene sleeve basically plays the same role in these cases. And then just to go over some ACL postoperative rehab. So early on, the goal is to preserve full extension and work on gaining 10 degrees of flexion daily. And then you really want to protect the graft. Continuous passive motion, those devices, there have been several systematic reviews that have demonstrated moderate evidence that there's no added benefit. And also regarding closed versus open chain, previous RCTs demonstrate superior results with closed chain exercises. Open chain exercises can lead to a 9% increase in laxity compared to closed chain exercises. And then closed chain led to greater knee stability, less patellofemoral pain, and greater overall satisfaction and return to activity. So thus the literature supports both open and closed chain exercises, but timing during post-op period is not super well defined. And just to get this on your radar, the bare ACL repair. So I don't know how many people on this call have like really heard about this, but it is upcoming, so something that we should be aware of. BEAR stands for Bridge Enhanced ACL Repair. So this is a repair, not a reconstruction. So the little device just looks like this, and then the surgeon injects the patient's blood into this sponge-like implant, and then just places it in between the two ends and tries to suture it in. So you place a bare implant between the torn ACL, add blood, the torn ACL ends into implant with stitches, and then you hope that the ACL heals and replaces the bare implant over time. Um, this is good for patients under the age of 40 with proximal tears, with greater than 75% of the stump remaining, and also recreational athletes. Um, Re-tear rate on bear in those under 22 years old were found to be 16 to 30%, which is compared to 6% in hamstring autografts in that same study. However, for whatever reason, they called this non-inferior, but I think, we'd probably agree that 16 to 30% is still a significantly higher chance than 6%. So overall, I mean, everyone's take is going to be a little different, but I don't think it's really great for young pivot/cutting athletes yet. And oftentimes this requires 2 years of rehab because it takes a little bit more time for that ACL to really incorporate into the region. All right, so the ACL is definitely the most information. The other three ligaments are a little bit more simple. So for PCL injury classification, I think it's important to know classification before we talk about the treatment for each. So grade 1 is when you have a partial tear. The exam typically shows 1 to 5 millimeters of posterior tibial translation, and the tibia remains anterior to the femoral condyles. Grade 2 is when you have a complete isolated tear, 6 to 10 millimeters of posterior tibial translation, and the anterior tibia is flush with the femoral condyles. In grade 3, usually it's with a combined PCL and capsular ligamentous injury. The exam shows greater than 10 millimeters of posterior tibial translation, and the tibia is posterior to the femoral condyles. In these grade 3 injuries, there's often an associated ACL or posterior lateral corner injury. So treatment for this, if it's a grade 1 or 2 injury, it's non-operative treatment. You do protected weight bearing and rehabilitation. The quadriceps rehabilitation with focus on knee extensor strengthening. And return to sport for this is typically about 2 to 4 weeks. If someone has an isolated grade 3 injury, then you do relative immobilization and extension in a hinge brace for 4 weeks. Then you limit daily range of motion exercises, followed by quadriceps strengthening, and then return to sport for these isolated grade 3 injuries is typically 4 to 6 months. You do have some like high level athletes that really push the envelope, and in football, they'll let them come back in 6 to 8 weeks with a PCL brace. And then if someone has an isolated grade 2 or grade 3 PCL injury with a bony avulsion, or if they have a combined ligamentous injury with PCL plus ACL or posterior lateral corner, or like an MCL, LCL, then you want to send them to your surgical colleagues immediately for operative treatment. Also, if they have an isolated chronic PCL injury with functionally unstable knee, operative treatment is probably a good idea as well. And return to sport from these surgeries is typically about 6 months or longer. For MCL injury classifications, grading, you look at like the distance between like that medial tibia and then the medial femoral condyle, and then you see how much gapping they have or valgus gapping. And then grade 1 is 3 to 5 millimeters, grade 2 is 6 to 10 millimeters, and if they're over 10 millimeters, grade 3. A modified way you can do this is just see if they have a firm endpoint with no laxity. That just might be a grade 1 like stress injury. If they have a firm endpoint, but they have some increased laxity, they could have an incomplete or partial tear, and that's a grade 2. And if they have no endpoint, then that's a complete tear, and that's automatically a grade 3. Treatment for this, if it's a grade 1, that's easy enough. You just do NSAIDs, rest and therapy, have them do quad sets, straight leg raises, and hip adduction above the knee to begin immediately. And usually athletes can return within a week from these grade 1 MCL injuries. For grade 2 and grade 3, if it's stable to valgus and full extension, no associated cruciate injury, then you can also treat this non-operatively. So this involves bracing, NSAIDs, rest, and therapy. For this, you probably want to go ahead and use a hinge knee brace to give them a little extra support to begin with. Return to sport for grade 2s are typically about 2 to 4 weeks. For grade 3s that are stable, it's 4 to 8 weeks. And then proximal injuries tend to heal better than distal injuries. Um, if they do have like an MCL injury, and then they also have an ACL rupture, a lot of times the surgeons are going to wait and let the MCL injury scar down a little bit for some of that valgus stability before they go in and do the ACL reconstruction. And then in terms of indications for operative treatment, that includes valgus opening and extension, if they have a deep MCL injury, or if they have a displaced tibial sided injury. And last of the major ligaments is your LCL. So grading for the LCL injuries is same thing. So you're looking at varus, and then from 0 to 5 millimeters, it's a grade 1. 6 to 10 is a grade 2, and then greater than 10 is grade 3. You can also grade LCL injuries by MRI. So grade 1 would be subcutaneous fluid surrounding the mid-substance of the ligament at one or both insertions. Grade 2 is partial tearing of the ligament fibers at either the mid-substance or one of the insertions. And then grade 3 is complete tearing of ligament fibers at either the mid-substance or one of the insertions. Treatment for this, isolated grade 1 or 2 with no instability at 0 degrees is non-operative. So limited immobilization, progressive range of motion, and functional rehab. Return to sport for this is typically 6 to 8 weeks. If they have an isolated grade 3 injury with bony avulsion, then surgeons typically want to repair this. If they have grade 3 with persistent varus instability, reconstruction is more indicated. And finally, if they have an LCL injury with a posterior lateral core injury and rotary instability, then reconstruction. And then here we'll have posterior lateral corner injury grading. So grade 1, 0 to 5 millimeters, grade 2, 6 to 10 millimeters, and then grade 3, greater than 10 millimeters. And then for treatment for this, non-operative. Okay, I'll continue. So for grade 1 posterior lateral corner injuries with isolated mid-substance grade 2 injury, that's non-operative treatment. You do a hinge knee brace locked in extension for 4 weeks, followed by progressive functional rehab and quad strengthening, and the return to sport is typically about 8 weeks. If they have an isolated grade 2 posterior lateral corner avulsion injury, then repair is indicated. If they have a grade 3 mid-substance injury, then hybrid reconstruction or repair is indicated. And return to sport from these injuries are typically about 6 to 9 months. And keep in mind, posterior lateral core injuries, if they are missed, and then you get like an ACL or PCL reconstruction, it could lead to failure of those. So very important to find. The last thing I want to go over briefly is just multi-leg knee injuries. Hopefully you don't see too many of these all the time, but these can be pretty catastrophic injuries and are like limb emergencies, right? So Nick Chubb, I think, had a pretty significant one a year or two ago, but this year he returned and is playing. Usually it involves a knee dislocation as well. So there's a shank knee dislocation or KD classification. KD1 is just injury to a single ligament, the ACL or PCL. KD2 is injury to both the ACL and PCL. KD3 is when you have your ACL, PCL, and then you also have either your MCL or LCL injured. And then KD4 is when all four of these major ligaments are injured. And then KD5 is whenever you have a knee fracture dislocation. They also let you include a modifier. So if you add a C to this, it would indicate vascular injury and would indicate nerve injury. The key thing with these is you really want to rule out neurovascular injury. So, on the field, you want to feel for pulses. If you get them more into the hospital setting, you can look at ABIs. And then you do any knee dislocation, you will want to get a CTA to make sure the popliteal vessels are okay. And then treatment is really reduction. Try to get it in line as quickly as possible to make sure you're helping out with that neurovascular injury. And then ultimately, these patients will have to undergo multi-stage reconstructions. So my key take-home points include that history and exam are key in identifying knee ligamentous injuries. Multiple imaging modalities can help confirm and grade these injuries. Pre- and post-operative rehab play a role in ACL reconstruction outcomes. There are many factors that play a role in ACL reconstruction graft choice. PRPN's role in ACL reconstruction is still being evaluated. Be cautious of posterior lateral cord injuries that may lead to failure of ACL or PCL reconstructions if missed. And also multi-leg injuries, first and foremost, require a neurovascular exam. So, to the good part. So here we have some CAQ questions that you guys can take a part in. I have 3 of them. So, Andy, do you want to start that poll? There we go. So the question says, a football player is seeing you for a knee injury sustained in a recent game. Following the game, he noticed his left knee did not feel right. He played the entire game, but the left knee felt like it was going to give out when he was running and planting. As you examine the player, you are concerned that he may have suffered an injury to his PCL. Which of the following is true regarding injury to the PCL in sport? A, injury to the PCL in sport is common and accounts for the majority of knee ligament injuries in sport. B, the pivot shift test is the most sensitive and specific physical exam for PCL injury. C, a common mechanism for injury to PCL in sport is a fall onto a flexed knee. Or D, most PCL injuries require surgery in order to allow athletes to return to sport. Perfect. Great. So I agree with everyone here. So common mechanism for injury to PCL in sport is a fall onto a flexed knee. So good job, everyone. All right. Question 2. Avulsion of the IT band off of Gertie's tubercle, biceps femoris avulsion of the fibular head, and popliteus avulsion. Can't see. Avulsion. 1 second. Are most likely associated with which of the following knee injuries? A, posterior lateral complex injury. B, patellar dislocation. C, medial collateral ligament sprain. Or D, lateral meniscus tear. Good job. So the majority of people chose the correct answer, the posterior lateral complex injury. Remember, that's something that we'll just keep in the back of your mind all the times. All right, and then last question. You diagnose an athlete with a grade 2 MCL ligament injury or MCL injury. Initial treatment would include which of the following? So A, knee immobilizer and crutches for 2 to 4 weeks. B, referral to orthopedics for surgical evaluation. C, no treatment, athletes cleared to return to play. Or D, hinged knee brace, weight bearing as tolerated, and range of motion exercises. Perfect. Yeah. So hinge knee brace, weight bearing as tolerated, and oftentimes you're able to return to sport in 2 to 4 weeks. So good job, everyone. All right. So that is the end of my presentation. Just wanted to share some of like my favorite things covering sports. I know if the majority of the people I think on this call are fellows, so after this year, the fellowship year is a lot of fun. Make sure you enjoy it, and then afterwards, it's really fun just building relationships. I think some of these covers. So this is during my fellowship year. I was covering women's basketball, and that was the same year they won the national championship. So I got to take a picture with them. I really love covering the UTA Wilshire Mavs. So this is a picture from there. This is covering Dallas Trinity FC. This is some international games I covered with some of the athletes from Japan that I had worked with. And then this one was interesting. So one of my friends, he is one of the docs for AEW, and they were in town. So he let me come hang out. And then my wife is a dermatology resident. So she served as like the event dermatologist. So she got to hang out there too. All right. Well, I'll open it up for any questions if you guys have any.
Excellent. Thank you so much for that great presentation, Dr. Kasitinon. I think this is one of those things where super high yield for both fellowship and afterward, and I think you brought up a ton of great learning pearls. So let's start with kind of a fun question. What do you think, patella tendon or ligament?
Oh, it is by definition a ligament, but I still call it patellar tendon because that's what everyone else calls it.
Yeah. No, and I think, if there are debates between PhD anatomists, surgeons, non-op folks like ourselves, the reason I bring it up is because, yeah, from a functional perspective, it works really well in the bone-to-bone grafts. And we see that, like you mentioned, because surgeons tend to use it more in our high-level athletes due to its, lower rate of re-rupture. So um, I think that's always an interesting talking point. Um, Thank you for bringing up the points about PRP. I do wonder if an explanation for why the more recent studies showed some benefit has to do with their PRP processing techniques, and hopefully that's improved. Maybe they have higher platelet counts or that type of thing. But I appreciate you bringing that up. Didn't know if you had additional thoughts. Um,
Yeah, I think that's a good point. I actually don't have because they didn't really publish like, what systems they use and like a lot of the PRP research. I think some of the newer PRP research is really looking at like, platelet count, platelet concentration, and the systems being used. But I think these studies did not necessarily look at that.
yeah, something that could definitely be standardized for sure. And then I think last thing I'll say about the use of PRP with ACL, certainly recons, is I totally agree with your comment about the bear procedure. Um, I did a quick literature search during you're talking. It looks like the first ever paper that was published in humans for bear procedure was in 2019, so still super recent, and something that I know I feel uncomfortable if a surgical colleague is talking to my high level athletes. This came up for one of our junior soccer players who ruptured his ACL at the University of Dallas at the end of his junior season. And it's like, look, we do not want to mess around. He's got 1 year left. Let's go bone to bone, and let's not mess with these new experimental techniques. Um, so follow up question about LCL. How often is like an isolated LCL sprain or rupture?
Hmm. I don't have a percentage, but I would say I don't think I've actually seen an isolated LCL injury.
Me
I don't
neither.
know if you've seen differently.
No, I haven't either. And I think that for me was a learning point in fellowship too. Is like whenever you're suspecting LCL sprain or you see it on an MRI, you want to be thinking about other injuries too. And I loved how you brought up the multi-lig injuries. You know, one of my takeaways is that if you ever see ACL and PCL ruptures together, think knee dislocation. Right. So I thought that was a great point, and especially looking at junior ABIs and getting CPA as well. One last question for you has to do with kind of an interesting finding that comes up on some MRI reads, and it ties into exactly how you were describing the Lachman test, right? The A or B portion. Do you have the endpoint? Do you not have the endpoint? I've seen MRIs come up where you see ACL sprain, and so one question for you is, what does this mean for athletes functionally, and how do you counsel them when you see that on an MRI?
Okay. Yeah, to me, I think once um like assuming you're looking at the MRI yourself and then you agree that it's not like a complete rupture and there are still fibers intact, but it just looks like that, like just looks kind of loose and like a sprain pattern, then I really rely on just the physical exam. Um, if they feel loose, I think still I would call it an ACL deficient knee and counsel the athlete that way. Um, but if they actually feel like they still have an intact ACL on physical exam, then I would counsel the athlete that, hey, I think it's reasonable to rehab this and see how stable your knee is slowly, because even though you have an ACL sprain read on there, you still have fibers intact, and on exam, your knee feels very stable.
Yeah, I think that makes a lot of sense, and it harkens back to the utility fees. Sure. Um, okay, maybe that was the penultimate question. One more question for the audience. Dr. Uden asks, he says, thank you for the informative lecture. Could you comment more on the prehab exercises? So you quoted the 2016 AJSM article that involved 5 weeks of prehab improving post-surgical outcomes. And then he mentions maybe a specific type of therapist to refer to, and then similar kind of more detailed question about exercise frequency. So in summary, could you say a little bit more in terms of the prehab?
Yeah. So I think for prehab, like probably the key things are really just keeping swelling down and then improving range of motion and then finally working on the strengthening specifically of the quads. Anytime you hear about the knees, you always talk about quad strengthening, but you can't emphasize that enough. So when you see these ACL ruptures in clinic, if they are really uncomfortable and their range of motion super limited, you can often offer them to aspirate their knee. I would not recommend injecting anything into their knee, but you can aspirate, and I've had plenty of patients that just aspirating like 70 to 100 cc's of that blood out of their knee. Number one, it takes that blood out that can be bad for their cartilage long term. And number two, like patients just from getting that fluid out report like 70 to 80% pain relief and allows them to do therapy much better. Um, and then in terms of the actual exercises, first, like I said, focusing on range of motion. I've heard most of the surgeons, if the patient can't get their knee past 90 degrees of flexion, they typically don't want to operate. Um, and then and then start working on that quad strengthening afterwards. If there's a particular therapist, I don't think so because it's such a common injury. Most musculoskeletal or sports therapists, I think, can handle the prehab for an ACL. So I wouldn't be too worried about that. And then Dr. Uden, the last thing, that is there any specific counseling on type of exercise and frequency we can offer to our patients who already participate in high risk sports? Um, I would say range of motion is like at least 3 times a day if they can do that, if they have the time to. And then in terms of exercises, you don't want to give them too much if you're going to send them to therapy. So because you don't want to contradict with them. But if you give them some some strengthening exercises, tell them to do it like once or twice a day.
I think that's great. Yeah, and I've also on the lip end of the 90 degrees of flexion, I've also seen surgeons comment on um, lack of full extension also being a barrier to surgery. So
It's a good point.
more reason to support the range of motion as primary. Okay, maybe one last one, Dr. K, and then we'll wrap things up. So Olawale asks about thoughts on the risk of the contralateral ACL rupturing after surgery, or essentially after repairing or reconstructing the initial knee.
Yeah, so I think there are like anyone who has an ACL rupture, typically they are at increased risk of the contralateral side as well. But I think that's not necessarily because they're getting the ACL reconstruction. It's just because their biomechanics, and as well as their native tissue properties are probably lean them a little bit more toward getting one of these injuries. So after they get the initial ACL reconstruction, it's really important to, if you have the luxury of having some sort of like true sports PT or a biomechanical lab to evaluate the way the patient or the athlete moves, I think that can be really helpful to prevent that in the future.
So more emphasis on continued rehab even after a recovery from surgery. Excellent. Well, thank you again so much for a super high yield talk tonight. Thank you everyone for tuning in, for your high yield questions. And then remember to join us next week for some more high yield x-rays of the hip and knee in our next edition of the Fellow Online Lecture Series. Thanks again. Everyone stay warm, and we'll see you next week.